Welcome to the Memora Health Care Delivery Podcast. Through conversations with industry leaders and innovators, we uncover ways to simplify how patients and care teams navigate complex care delivery.
Hi, everyone. This is Dr. Jamie Colbert, Chief Medical Officer of Memora Health and host of the Care Delivery Podcast. I'm joined today by Dr. Arun Mathews, the Chief Medical Officer at multiple facilities within Multi-Care Health System in Washington State. And Arun, really, I'm excited to talk to you today with your background in health information technology, your strong background as a clinician, having led hospitalist programs in the past. As I think you've heard from our previous conversations, I myself am a hospitalist, so I'm always excited to get to chat with others about our trade. And to start off, why don't you just tell our listeners a little bit about yourself and your background?
Of course. Thanks for having me, Jamie. It's such a pleasure to be on the podcast. So a little bit about myself. I was born in South India, raised in parts of Africa, the Middle East, did the International Baccalaureate as a high school student, which allowed me to apply to medical schools in Europe. And I went to the Royal College of Surgeons in Dublin, Ireland as a result of that. Hopped over to Baltimore to do a residency in internal medicine, which is where I met my wife. And then I did a fellowship in clinical informatics, a research fellowship at Hopkins. And because we were both foreign medical grads, we essentially had to spend some time in a medically underserved area as part of our J1 waiver sort of road to our green card journey. So I had the opportunity to work for Apogee Physicians as a program director in a small startup program in southeastern New Mexico, and then transitioned on to a program in Midland, Texas, where the CEO and CIO had, I think, discovered my background in clinical informatics. And that was when meaningful use stage 1 and stage 2 were starting to hit. And I distinctly recall the meeting where the CEO and CIO sat me down and said, Arun, do you have any interest in going to meetings and being yelled at by your colleagues? And that sounded fantastic. Yes, all of a sudden I became the implementation lead for our transition from paper medical records to an electronic medical record. That was the McKesson system at the time. And then I transitioned over to a full-time chief medical information officer as we did a system-wide transition from McKesson to Cerner. I was in that role, and our chief medical officer at the time departed. And because I was doing about 80% patient safety and quality work, it made sense that I kind of inherit into that role as a CMO, CMIO. Doing that for a few years, I looked at opportunities around the country and saw that multi-care was expanding, and there was a really interesting opportunity to not only be a CMO of a facility, but to actually open a brand new hospital. And that was something I'd never done before. And so 7 years ago, hopped over to the Pacific Northwest with my family and have been here since. We opened the Covington Medical Center in April of 2018. And then I feel like the second act of my career here at Multicare has been working through the pandemic piece and then the post-pandemic era, and then helping to shepherd some interesting conversations from a technology, innovation, and possibly even venture capital standpoint on a system side, while also maintaining my operations hat of those two facilities. So that's a little bit about me. Apologies for the verbal diarrhea.
No, it's a great journey that you were able to describe. And I have so many questions, but before we unpack some of the meatier topics, I'm actually really intrigued by your experience in New Mexico, because before I went to medical school, actually way back in college, I spent a summer bumming around New Mexico, doing a lot of hiking and camping. Ended up going to almost every corner of the state, and I really fell in love with it. Where were you living in New Mexico? I'm curious.
We were in Hobbs, New Mexico, the southeastern corner out nearby Carlsbad and very close to Midland, Texas. And I have to tell you, it was a magical experience for us. It was my wife and I's first job outside of residency. We were both starting up that hospitalist program. We had just an incredible small team of hospitalists that we just cherish those memories of bringing inpatient specialty care to that facility and working with the community physicians who had been holding that facility up for many decades. And honestly, it really spurred a genuine love and appreciation for rural medicine and the unsung heroes that inhabit rural healthcare centers all around the country with very limited resources, taking care of huge swaths of geography and doing it the best they can. Honestly, it was just such a foundational experience for us.
That's really amazing to hear. I think that we as a country just owe so much to the physicians who are making those commitments to move to some of these rural underserved areas that are just so in need of clinicians. And they're so appreciated, right? That these physicians are willing to come and to take care of these populations. How many beds were in your hospital? I'm curious.
Oh, it was a 200-bed regional referral center,
Yeah.
Good-sized hospital.
Yeah, it's decent size.
Yeah, we had, I believe, an 8-bed ICU, and we were it largely in terms of both acute inpatient care and a lot of the subspecialty care. When we needed significant subspecialty care and or interventions, we would rely on our community partners at University Medical Center, UMC, Covenant, based in Texas, to help manage some of those transfers out. But my goodness, talk about managing some incredible pathology and really spreading your wings in terms of all of the nooks and crannies associated with internal medicine. It was, definitely a foundational experience.
I have to say, I've always had a soft spot for rural medicine. I grew up in a small town in the western part of Massachusetts. And when I was doing my residency, I was in a city, but I did have the opportunity to spend a month on the Navajo reservation, actually, in the northeast corner of Arizona. And so that was a really eye-opening experience to be working in their very small hospital. We're talking handful of beds. And for anything serious, you would have to fly those patients out to Flagstaff or to Phoenix. Really, it allows you to operate top of license because most of the specialists are just doing video consults. And you as the generalist have to be comfortable managing everything from ICU issues to some more specialty specific concerns, whether that's cardiac, endocrine, gastroenterology issues, or really amazing to be able to fully practice top of license in some of these settings.
That is so true. That is so true. And I will say the relationships that you make and how closely connected nursing and the ancillaries are to you as a physician. Just you walk in, and that is certainly why I think I'm drawn to community medical centers. I purposefully chose Auburn and Covington medical centers because of that culture of when you walk in through the door, you largely know everyone by name, you recognize familiar faces. And that's a part of my core need, I think, as a physician when I walk into a space. I love understanding kind of all of the personalities and having deep-seated relationships with the healthcare team so that we can actually function together truly as a team and get patients out of some tight spots.
Yeah, that's something that I'd love to explore further. So tell us about some of the big challenges that you're facing in your current role. What are the things that are top of mind and keeping you up at night right now?
Of course, post-pandemic, we never really saw, at least at one of our facilities, a reduction in the congestion in our facilities. And we routinely live at about 110, 120% capacity. And what that translates into is incredibly congested emergency rooms, patients on gurneys, waiting for inpatient beds, inpatient doctors coming down, managing a lot of care and then us as an org having to learn how to manage that special and unique type of care, because we consider patients that are boarding in the ED to be a vulnerable population. Their care is fundamentally a little bit different. It's almost a hybrid care between the inpatient nurse that comes down to help manage the care, but also the ED nurse that still has sort of agency and can assist with more emergent instances. And then what do you do when you're in a hallway about things like mobility, about things like frequent turns, about managing regular interval medication administration with the rigor that would occur on a medical floor, but in the tumult of an ED space. How do we, as an org, learn to do that safely, effectively, and with a high degree of reliability? So we're in the midst of a high reliability journey, and this has certainly been one of those leading edges in terms of learning how to build a new culture around managing this type of care.
Now, you have a background in informatics. So curious, how are you thinking about leveraging IT to help with some of these challenges that you're mentioning?
Such a great question. Honestly, one of the great gifts of informatics has been this notion of appreciating that with any technology intervention, it is people fundamentally, then process, then technology. And people and process, I don't think is unique to the space of informatics, but it certainly harkens back to the strength of needing to define a vision, make sure that you're transparent with your communication pathways, both bidirectionally, as well as recognizing that healthy teams have degrees of redundancies and safety nets, and that we recognize that we need to extend grace so that we can build trust, so that people can be human, people can act out from time to time, and that's perfectly understandable when we are expecting them to undergo a great deal of change in a short period of time. Once you manage that relationship part, then it's all about the process. We use an ID PDSA methodology here at Multicare, which is all about breaking the process down into its constituent parts, doing tests of change, respecting the complexity of the Gemba or the workspace, and not overly simplifying these processes so that we recognize that in complex systems, when you make a simple change, there are often unintended consequences. And after we've walked through these tests of change, then we get to the actual technology implementation. You have to do the people and the process work up front and gain that trust so that then when you roll in with the technology solution, people are ready and willing to recognize the value that this brings. But even that value comes at a cost of workflow changes. And fundamentally, the question that it always boils down to is, how is this going to change my day? And is this going to make the time that I return back home to my family and my safe space, is this going to impact that? Like these are perfectly reasonable explorations and questions that we need to have. And so we take that approach as we look at technology solutions. With regards to the boarding challenge and capacity management piece in general, stepping back, our big concern is this notion of throughput. And on the front end of the hospital, that's the ED, and that's where the congestion is occurring. But throughput fundamentally is all about our patient progression and recognizing that getting a patient to a safe discharge and working with our hospitalist teams is what opens up that capacity to allow for the congestion to be alleviated on the ED side. And then if you contemplate stepping back from the hospital writ large into the management of the hospital in a larger healthcare system context, now we get into a technology application around capacity management. And so I think if you were to ask me, the simplest sort of way that we have started to manage our capacity at Auburn Medical Center was actually developing a mission coordination center for the entire health system that could look at capacity and do things like level loading and capacity management in real time, understanding things like staffing, things like acuity, things like when an ED was overwhelmed, how to effectively divert. It's the technology that we've implemented in our Multicare Coordination Center that I think is having a genuine impact on our ability to try and manage reasonably effectively our capacity challenges in this one particular facility. And that's probably my short answer to addressing that technology approach with regards to managing our capacity and boarding challenges specifically.
Yeah, I like that you're really identifying explicitly the people challenges that are part of using technology in healthcare, and the fact that adoption is critical, and convincing staff members that technology is going to have a positive impact on them is really the biggest part of the battle here. So I'm curious if, in thinking through some of your other experiences working with technology in current role or prior roles, there were IT implementations that did not go well, right? Where the staff just did not buy in, or they didn't feel like it was truly helping them. And I'm curious just to hear a couple learnings from that didn't go well.
No, I have I think a very timely example of something that initially felt like it was not going well. And then it was really doubling down on the people aspect that actually helped us change that script. Mid-pandemic, because we like to take on big projects in the midst of unprecedented global pandemics, we opted to explore. To be fair, it was understandable because mid-pandemic, there were tremendous challenges placed on health systems from a supply chain standpoint, from a finance standpoint. We recognized that there existed opportunities around clinical stewardship to essentially make sure that we were practicing the highest quality medicine that was evidence-based, that was also reasonable steward of our resources. And so we engaged with a health technology company that was focused on clinical decision support, but with a sub-focus of that clinical decision support around clinical stewardship. And we rolled out this clinical decision support at the point of care tool, and the company's name's IllumiCare. And we shared it. We did our standard sort of people engagement and process engagement, which included, we shared the why. We shared with our physicians that this was applying the best clinical evidence, namely the ABIM Choosing Wisely database of interventions around standard hospitalist care. And it would remind you really at the point of decision-making about opportunities around clinical stewardship. Let's give you an example. So patient comes in for an acute API, set of labs are done, magnesium's a little low, needs to be topped up a little bit. Because the patient's NPO for surgery, you're repleting with IV magnesium. And post-op day 2, the IV magnesium is still running. Magnesium is, let's say, still a little low, but the patient's able to take PO. And fundamentally, because now the gut is available, oftentimes because the hospitalist and the healthcare team is just bombarded with the task of trying to get the patient home, that one little decision to switch over from IV to oral magnesium with a delta, with a cost differential, can sometimes get overlooked. This technology would essentially just bubble that up to your awareness at the point of decision-making to say, hey, ABIM Choosing Wisely states that it makes sense to use PO when available. Yeah. And we shared that rationale. We shared that we felt fundamentally it was good medicine to follow these evidence-based protocols, and we rolled it out. And subsequently, crickets. We did lunch and learns, and we engaged our docs, and our docs were good sports about clicking into the app and just showing that, they look at the intervention, but they didn't change their behavior. It wasn't enough for them to say, you know what, I'm going to stop this, go into my other order profile and change it. So when we came back to the docs and we asked them, is there something about the tool that you don't like? Is it the user interface? Does it take too long? What's going on? We had some very earnest conversations with our hospitalists, and they were like, what? Here's the thing. Clinical decision support makes my day fundamentally worse. Oftentimes, the bog standard decision support is stuff I already know, and I'm just trying to click through to get through to my day. And then when I see these clinical stewardship alerts, I can't but help feel like I get this notification that's evidence-based, and now I have to do this thing where I reconcile that evidence, confirm that it's valuable, and then reconcile that with my plan of care for that particular moment, for that particular patient. And now I have to go into the ordering pane, stop this medication and start a new medication or change my order. It's just too much. It's just too much. And I was like, and that was a big a moment of awareness for us. When we actually took the time to do a workflow diagram that gave us a sense of the cognitive load, what each of these alerts resulted in, that was powerful. That made us realize, look, there's value here, that we're asking the docs to take on this extra cognitive work. There needs to be some sort of recognition of that. So as it happened, we are working with our sound physicians partners, and we were due for a revision of our quality metrics dashboard. That's the incentives that we put in for things that we consider as a health system important that drive forward quality. So we actually partnered with Sound and Illumicare to develop and design a clinical stewardship metric that would allow for shared savings. So we targeted, I think, something like a $16 total cost of care reduction, very sort of conservative estimate if the physicians partially interacted with this tool. And we shared with the docs that, look, it is not only if you're practicing evidence-based medicine that results in shared savings for the health system and the patient, you should get some sort of recognition for that. And so we were like, okay, we've designed this. And then we said, wait a sec, shared savings programs, that the hairs on the back of our compliance heads started rankling a little bit. Are we paying doctors to ration care, et cetera? So we then partnered with our legal and compliance teams, and we did a search of the literature to look at shared saving, the ethics of shared savings programs. And we were pleasantly surprised to find that there are multiple precedents for this in health systems around the country that fundamentally show, primarily in the orthopedics world, but we also found some in the oncology spaces, that these types of programs do move the needle in terms of behavior change. So we presented that to our legal and ethics partners in the form of an SBAR. They came back saying, yes, what fundamentally, because you are not forcing these decisions, the practitioner at the end of the day still has the agency to say yay or nay with the recommendations. However, we do recommend, because this is a novel, new quality metric, we recommend a countermeasure assessment, whether it be patient experience or readmissions, and we decided to monitor both. So long story short, I apologize for all of the extra explanation, but it enriches the story. Long story short, we rolled this out through 2023 and were blown away by the uptake and the engagement by our physicians now that it was recognizing that the work that they were doing cognitively had value and they were getting a recognition of that value. All told, I think we had anticipated a total cost of care savings per patient at around 16%. We are now appreciating a total cost of care savings of about $75 per patient, which amounts to, for that limited pilot that we did in the Puget Sound region of about 5 hospitals, about $2.5 million worth of total cost of care reductions. That felt tangible and important. And with those savings, that's potentially another program that we can invest into for the community. And that was, I think, an example of going back to the drawing board, recognizing the fundamental tenets of informatics being, hey, start with the people and investing in the people to understand what their concerns were with the technology, and then rolling out a platform that was really in partnership with our hospitalists. So that's, I think, the story that we're continuing to explore together.
Arun, I love that story. It just really highlights so many great examples of human behavior, how to motivate change, because we know that change is so difficult in organizations and in healthcare in particular. When we're dealing with patients' health, we're dealing with practices that in many cases have developed over time and routines, right? It can be very challenging to change how things are done in clinical settings. And so I think this is a remarkable example of implementing a technology that was really meant to improve care for patients, to ensure that evidence is being followed in clinical decision-making. That's also helping to use resources most appropriately, such that we're not wasting valuable resources. We're trying to keep healthcare costs down. And so I think it's really a fantastic example for us to end on, to just help to highlight all of the opportunities to look at when something's not working in healthcare. How do we go to the Gemba? How do we make sure that we're really looking at what's happening on the ground? What are those minute steps in the process that make up the day-to-day workflow processes of caring for these patients, making sure that they're getting what they need? And then we see, where are there pieces of opportunity for efficiency, better interventions, et cetera. So on that note, I think we are going to have to end, because unfortunately our time is up today. But Arun, I thank you so much for spending the last half hour discussing this with me, sharing your story, your insights. And until next time, this is Dr. Jamie Colbert from the Care Delivery Podcast.
Thanks for having me, Jamie.
Thanks for listening to the Memora Health Care Delivery Podcast. For more ideas on simplifying complex care for care teams and patients, visit memorahealth.com.